Welcome to the Health Tech Edge, the podcast on how technology is reshaping healthcare operations. I'm Mike Moore. Today's conversation is about something we haven't covered yet this year: rural healthcare, hospital closures, access issues, and how AI and digital tools can actually help or make things worse if done wrong. I'm joined by Mitchell Fong. He's led virtual care at scale, worked across payer and provider environments, and now advises organizations on digital health and operations. Mitchell, good to have you here.
Thank you, Mike. It's a pleasure to be here.
So let's get into it and start a bit with your background. You've worked in virtual care, population health, operations, not just strategy, but actually running teams and programs. What did you see firsthand when you were scaling virtual care programs?
Well, I guess I saw a lot because I started pre-pandemic, and I think one of the biggest things was the stigma, the change management. I would say if we're looking at what's a critical point of success, I think that skill and that culture is something that needs to be ingrained, whether that's an urban or a rural facility. But I think you see a drastic change between the resources and the culture around change in rural environments compared to more urban environments that are maybe more adaptable and have more new pilots and projects flowing through the system. So I think that's been one of the biggest changes, specifically with technology. I think the stigma has always been a big challenge. When we first started with telemedicine, it was, are you sure I can deliver the right level of care, the right quality? Will it be able to support the needs that I have as a clinician to deliver that quality and not jeopardize the care that I'm delivering? And alternatively, are the patients ready for that? Are they scared of the technology? And I think as we're seeing AI roll in, that stigma is coming forward even further with what is the AI doing? Who's going to have access to this data or my information? And then I'll say the last other aspect of it, I think, is just that digital divide, both from the connectivity, the bandwidth, the resources, but also just the inherent access. So being in the algorithms to represent those rural communities, is that a challenge for some of those AI technologies that we have there where we have induced bias? And what we want to make sure we're not doing is exacerbating that digital divide, but hopefully using the technology to close that gap.
Yeah, I think it's important what you raised to the point about the clinicians and their perspective on virtual care. We so often think about the patients and what their experience is like, and the fact that they're not going to be in the office, which is what they're used to. But it is important to consider the clinicians and their perspective too. They have an oath, right, that they've sworn to do their best and do no harm and right and take care of patients, and they have to use their full set of skills and their, observation skills that they have, especially sitting in the exam room with a patient. There's nothing better. And obviously then there's diagnostics, labs, kind of other testing that they might, want to order as information sources to kind of bring into that conversation. So it is that physical separation for them, and kind of how you meet their needs, and use the technology to do it, as well as obviously the patient experience. And both sides need to trust in that to have a successful virtual visit, right?
Yeah, absolutely. And I'll say, particularly earlier on with telemedicine pre pandemic, a big part of the challenge was how many of these providers were exposed to these tools when they went through their education, when they went through their medical training, and how many people are asked to deliver what they do at the top of their license in any job without being trained with those tools. And I think that was a big challenge that we underestimated as an industry. What that looked like on the impact, not just to deliver on their oath, but also to be satisfied at work and not be burnt out with technology. I think that's a big challenge. I think now we're much further along, well past the pandemic and COVID, where we see it natively ingrained into education, residence training programs to use telemedicine, virtual nursing, et cetera. And so there's a lot higher literacy, and I think that stigma is reduced. But it doesn't mean that it's not invasive to put technology in a workflow if it's not done right. And so I think that part is still very applicable. But what we saw early on was really just, how am I supposed to deliver medicine in a way that I've never been trained with tools I've never seen? And so really having to create the education, that support, that change management, but also understand that burnout on what it mentally does on the clinician and their team and the ancillary staff as well. I say clinician, but it's really the entire care team, front office, back office staff as well that's impacted. What does that do, and what does that disruption cause? What are the unintended consequences? So I love what you said, and I agree with it completely.
Yeah, I think what's important there, as you're emphasizing, the pandemic brought everyone to somewhat of an even playing field, or close to that, because no matter whether you were in a big city or out in, the heartland or wherever, across the United States, everyone was in the same situation where we were stuck at home, and only the most urgent cases were leaving the home and going to the hospital. And we've seen the stories, that the kind of the heartbreaking moments throughout the pandemic, especially the early cases of COVID, and kind of what our healthcare workers and patients and families went through, and the terrible losses that occurred. Now, kind of post COVID, post pandemic, being able to learn from that and also kind of take some best practices away from that. People were kind of, as you said, you worked on some of these initiatives prior to the pandemic. Everyone was forced into it during the pandemic. Now, post, we've got all that kind of learning that comes into it. So, there are still the social determinants of health. We talk a lot about kind of transportation primarily as one of those issues. And having a senior parent who needs access to care sometimes when my wife and I are both working, my sister is out of state, taking parents to it, telemedicine and virtual visits becomes a great opportunity as long as there are the right clinicians there to match up with kind of, people's needs when they're trying to seek care from home.
Yeah, absolutely. It's the right care at the right time, the right place, which means it's the right clinician, which means you have the right access. Whatever payer you have is credentialed with that, or the provider's credentialed with them, so you're able to access them. I think all those facets combined are what makes a virtual experience very good. I think as we're looking at those rural communities, to your point, it's how do we build out that infrastructure so that whether it's at home or at their local clinic, that they're able to get that right care at the right time in the right place. And further, how can we use AI or new technology that's coming out now to really streamline the process and be able to elevate the level of quality care we can deliver in those local communities rather than relying on transfers or patients to travel exorbitant amount of miles or hours to really get to those specialty appointments that they need. But are there ways that we can make healthcare more convenient, where we can make being healthy part of your daily life instead of make it invasive to what your daily life and your daily routines are?
Yeah, so let's talk a little bit more about that and really get your perspective. There's a lot of discussion about rural hospital closures and healthcare deserts, access issues, these kind of issues that we're discussing here. So, from your perspective, what makes rural healthcare fundamentally different from urban systems?
Yeah, I think you can go a lot of directions, but I'll just start with access from a resource perspective. Even at those critical access hospitals, do they have all the same specialties that an urban hospital has? No. And even if they have access to those specialties, let's say a cardiologist, are they there every day of the week? Or are they there 1 or 2 days a week and they're rotating between different communities? Think about in the hospitals, do they have the ability to do some of these services that you might need to stabilize, or will they have to transfer? And so when you truly just think about that rural environment, I think you start with that access and the specialty, and then you think about what's the trickle down effect from that. You probably don't have as well built out and staffed teams on both the back end and the front end for those clinical ancillary teams. You likely have to drive farther distances to get to your care or to that pharmacist. You might have limited hours to each of those entities. And so when you really think about it, I think the infrastructure that's there and resources are vastly different, but also your ability to just get what we might in an urban setting think is common, to just run to any store, any CVS, and you can get it. Even if the one down the street is closed, I'll go to the other Walgreens that's just a couple blocks over. And that's really just not the case in those rural communities. And so I think sometimes that's an overlooked challenge. And something as simple as broadband, when we talk about telemedicine, do they even have connectivity in their home? Do they have smart devices that can connect to their home? And what is their digital and health literacy for those patients that are really needing that care? Are they going to be able to self-service this, where maybe in an urban environment, many of us are used to working from home or doing a lot of things on our computer, and broadband, having very strong broadband is a standard. That might not always be the case in those communities. And so like, just thinking through the digital divide, the resources, and then the last thing I'll say is the reimbursement, the payer mix and how they're paid is very different, and so the incentives and how they align might be different from a rural system versus a urban system.
Yeah, I think the point there too about this is that it kind of, it's still on television. There are these kind of quaint shows that show the small town doctor giving primary care, from birth until, death, which may be true in many communities. And you referred a lot to specialty care, but I have to imagine that there is a gap between primary care needs and kind of what's available in some of these markets as well. They just don't have enough primary care docs.
Yeah, absolutely. Primary care is a gap. I mean, every specialty, but primary care for sure is a gap. Urgent cares, you don't really see them there. You just kind of go to the hospital emergency room if they have a critical access hospital. And so I think just those resources in general are lacking.
Yeah, and I think one of the things when we spoke earlier too is that you mentioned, digital divide's not just broadband, but it's the data too, right? And having access to the information and resources. Can you speak a little bit more about your perspective on that and how that impacts this rural healthcare challenge?
Yeah, absolutely. I think when we look at AI and how they're trained on data sets. A lot of times we're looking at data that comes from primarily urban populations. And so, how are we really reflective of those AI systems looking at and taking into account some of those unique challenges of those rural patients, I think is often overlooked. And obviously, it has to do with some of the resources, but just I think some of those communities in general, the way that they access care, some of their providers are honestly still using pen and paper when they take their charts. They're not on electronic medical records. And so, how can those medical records be in those algorithms? How can they represent some of those communities? I think that in itself presents one challenge. But then, further, what's the literacy to be able to use and understand that data? I think we're seeing the level of sophistication increase, but also that level of general intelligence increase across the broad community, and patients in general are more educated today around healthcare than before. But are we able to deliver the same training and resources to all of those rural patients that may not be going through the traditional settings that we see in those urban environments? And so I think those are some of the challenges that we see related to that level of care and being able to deliver it effectively.
So, are we talking kind of as an example, maybe like native populations and some of the health issues they may experience, or what are some examples here where we might see that?
Yeah, I think definitely in native populations. I think in health deserts in general, a lot of the algorithms for triage that are created today for AI are recommending patients to do X, Y, and Z. Go to your closest urgent care, do this virtual visit, etc. But if in that rural community you don't have an urgent care that's nearby, how is that a meaningful option for me in my environment and with the challenges that we have? To your point, we know that different populations are susceptible to different conditions at various rates. And so, for the tribal population, are we underrepresenting some of the challenges that we have in that? And I think that also goes to rural populations broadly in those frontier communities that really are not accessing care. They're not always reflected in those populations. And we think about prison populations and what we're doing in healthcare, because if the goal is as these people are released from prison, we're setting them up on a second chance of life, if you will. Then a part of that is obviously the social and economic aspects, but a part of that is health and being able to understand how to manage and maintain your health so you can put yourself in a good standing to be able to be successful and thrive. And are we giving them the tools to understand how to get those resources for patients that are getting discharged on medication? For some of them, they have to find out how to do the paperwork on their own to now be eligible for Medicaid and go through that process. And they're sometimes stuck in a rural community where their prison was, that they don't have any family or resources out there. And so, how are we really supporting those individuals in getting back to that opportunity at life to really have good health, to have a good job, and to really learn from what that experience was for the second opportunity? I think when we think of some of those communities, those are ones I really think are underrepresented. I think obviously I'm talking a lot about rural and tribal and prison, but I also think when we go to different demographics, those are important things to look at in general.
Yeah, I was at the Becker's Payer Issues Roundtable this week in Chicago, and one of the speakers who creates health plans, kind of for specialty communities and these kind of settings or employer plans, was speaking about the fact that when you're rolling out a plan, so often people the only thing they kind of hear and remember in their plan is what their copays are for specialty visits. They kind of miss the piece that preventative care is covered, fully covered, no copays. And they miss going for those preventative visits because again, their mindset is if even though I have insurance, if I go to the doctor, it's going to cost money. And they may be avoiding that because of the unknown. And it's almost one of those head in the sand. Well, if I never get tested or examined, then I won't get diagnosed, which then means I won't have to pay for. We hear so much about medical cost and medical debt that people carry, right? These are kind of the mindsets and kind of generational things that people deal with that avoid the healthcare system, which just is obviously going to create sicker populations ultimately that by the time they need care, they are in the most expensive care setting in the emergency department with, big interventions, potentially coming their way because that's what it's going to take to save them at that point. I don't know if you've seen kind of those issues and how you break that stigma and kind of the cultural piece as well as kind of there's the information piece to just kind of break through and help people want to access care and realize that there are options there for them that are covered or are affordable, try to help them overcome that.
Yeah, and you hit on something I think is fundamental in healthcare in America, which is our system historically, the unintended consequence of the way that our system was created was to reimburse for sick care. And inadvertently, we created a culture that we all grew up in, which is you only go to the doctor, you only get health or medical care when you are sick. And so now we're trying to figure out how do we change that continuum or how do we change that mindset so we think, hey, let's invest in being healthy so we only have to get care when we're actually sick, and hopefully that's rare. Unfortunately, I think we're in this perspective where many of us are trained that we go to get care when we're sick and we don't have to go to get care when we're healthy. And to your point, that's kind of that unintended consequence of the system where we're trying to release and provide these benefits, but people aren't aware of them. And so I think a big part of that is, to your point, that education, that health literacy of understanding what is the goal for our plan and what we want to do, and how do we really push these programs to get upstream from a population health management perspective. Say, we really want to treat you when you're healthy to keep you healthy. We know that we will be here to treat you when you're sick, but the goal is to be your partner in health when you're healthy. And I always say that with tools and AI and all these new health tech applications that I see all the time. And in my mind, I think of how is this going to be native in the everyday person's life in their ecosystem to say this is going to support me when I'm healthy, so that there's no question where to go when I'm sick. And I think that's another part of what you didn't ask, but unintended consequence of high spend in that medical debt is that when people don't know where to go, they end up going to the emergency room when they could have gone to the urgent care. They go to urgent care when they could have gone a virtual visit. And so, both from a resource capacity for the entire community, we're using high intensity resources on something that may not require that level. But then, from a patient perspective, we're probably paying exorbitant amounts for the level of care that we didn't really need, that could have been treated maybe faster, maybe more conveniently, and very likely in a lower cost setting if we were to be upstream with that care. And a big part of getting upstream is understanding how do I use the resources when I am healthy to keep myself healthy. And then a part of that, I think, is that data and that trust. How do I trust that the information I'm getting is real? How do I know that they're not capturing this information just to increase my rates? I hear that all the time for
Sure.
people not wanting to use population health tools is I think they're just trying to capture this data so they can add more diagnosis and make me seem more sick and collect more money off me. And really, it's an unfortunate stigma that I think we have as an industry because of factors out of our control, but just kind of how the insurance market has always worked and how pharmaceuticals have a high markup and there's lack of price transparency historically. And so I think we're really combating that now. And your question, really, sorry, going to the root of it, was how do we, from a change management perspective, change the culture of healthcare in America? And I think it starts with education across the board. It starts with really pushing the value proposition of all of these preventive medicine programs and plans, and really introducing and pushing, almost forcing, but I'll say that's not really the right term, but really encouraging these patients or these members to get that proactive care, to incentivize them for that so that hopefully there's savings on the front end, not just on the back end for the providers, the payers, and the systems, but how are we delivering value for the patients that they can quantify and understand without it being invasive in their life? And so I think it comes with education, it comes with opportunity, and natively, as we think of technology, it comes with how do we make this very convenient in my everyday life to use these tools and to know how to access the right tools in the moment so that I'm not stressing or thinking about it. I mean, we in healthcare that work in healthcare, even if something happens to us, we tend to get a little bit scatterbrained, like, oh man, do I go to urgent care? Do I go to emergency room? I don't know where to go. I should just go where I know I can get all the care at one time. And if you think that us as healthcare professionals think through that, what is the common person thinking about healthcare when it's so challenging to navigate and you don't get tip sheets really on how to know where to go to emergency room or virtual care or urgent care? And so that's where we have to do a better job as an industry of creating those pipelines, creating that education, and pushing those tools out in a very user friendly fashion that hopefully isn't 20 different tools, but hopefully it gets to one consolidated tool that at least has call outs via API or whatever to be able to support you in all the support that you need and get the right services. I know that was a bit long winded, but hopefully I hit on the actual core of the question and didn't just stand on my soapbox there.
No, no. I mean, I love a good soapbox and some passion, especially around healthcare transformation, whatever the issue or the dimension is, because change is obviously needed. And a lot of the ideas that you're espousing there, they need support and funding to make these kind of transformations happen. So let's dig in a little bit there and talk about some of the funding that's flowing into rural health right now. You've got state managed programs, HRSA grants, flex program support, broadband investments. Just walk us through some of the transformation funding opportunities that you're seeing and what you think are some of the opportunities.
Yeah, well, I honestly think it's huge opportunities. It's hard to answer that in a short, succinct response, but $50 billion over 5 years spread out across all the states just for the rural communities, I think is fantastic. Then when I think of the opportunities, I think it's really endless with what we can do with data, what we can do with collaboration, knowing that 1 in 5 rural hospitals are closing. It's both a combination of how do we better support those communities with hospitals closing, and secondarily, are there ways that we can support these communities to keep those walls open, those doors open, so that we can have access to some form of support in those communities? I think when we think of how AI or technology will really play the biggest factor in the rural communities, it's not at all to replace the resources that are there. They're already constrained with the resources. It's how do we take some of those administrative tasks off their plate? How do we allow them to streamline the care and provide additional context or intelligence so they can deliver higher level of care? And how do we elevate the game so that we can collaborate across communities to share some of those specialists where patients can get that right care in the right time? And we know that patients recovering in a place of comfort, so in their home environment where their family can visit them, increases the outcomes from a health perspective. And so how do we ensure we can put those patients in those communities or leave them, keep them in those communities so they can have that emotional support and the family can have that emotional attachment to those patients and support them through the process and the recovery and transition to home? Because a lot of times, if the patients have to go out, cross state lines or whatever, hundreds of miles away for the right level of care, they feel isolated while they're getting their care. And their family themselves also are worried sick. And then when you have that transition, it's not always as smooth a transition because you don't have that continuity, you don't have that familiarity. And so I think those are huge opportunities for us to really think about where technology can play a factor. I think when we think of triage and connecting people across those state lines, that's absolutely an important part. But when I think of the rural health grants, the biggest concern that I have is it's a lot of money, which is great. But how are we going to make sure that the money is spent in a way that's both delivering value today, but creating a sustainable infrastructure that can grow and scale for tomorrow for these communities? What I would hate to see is that $50 billion be spent on projects, even if they're fantastic for this 5 year period, but then see a lot of those programs go away beyond that 5 year period. And I know that's not the intent of those funds, but that is one of the worries that I have. And if we don't really support those communities with a holistic approach on how to use new technology and data, we're just going to be building another silo within that community that over time can create more division and divide instead of hopefully over time layering on new opportunities for growth and sustainability with that technology and data. So I know wasn't very specific in that response, but I think on a broad scale, there's a lot of things we can do from the resource, from the infrastructure, from the data, the triaging and getting access. But I think it's most important that we're delivering true value for that community based on what they need and what their gaps are and their opportunities. What can they support successfully, which will be different in every rural community, but also that we're building from a sustainability perspective programs that will last beyond the 5 years and continue to drive value and hopefully really be the foundation of what that next evolution of technology enabled care would be in those communities.
Yeah, what I like about what you said there too is thinking long term. It's easy to think about the short term and the needs of the patients and that community today and what specialty care they might need or those kind of issues. But just to, if we take the major city that's in a market, we add virtual care capabilities to extend the reach out to those rural communities. But then from a billing standpoint, all the revenue is still coming back to the big city hospital or health system that's doing it. Nothing really is invested long term in building any kind of infrastructure programs, community access, safety net, whatever kind of systems, in those, nothing's ever going to change long term, right? There, you're just, in theory, you're creating a bigger hub with a broader reach, which has value, obviously, but still, it doesn't address some of those core issues. How do you see communities balancing that and kind of thinking about where the revenue lands, what they're able to build out for long term, and those kind of issues?
Yeah, I think from an urban perspective, they're thinking about it exactly as you laid it out. How can we do better with our existing resources to support the broader communities that we support? But from that lens, to your point, they're looking at we need to make sure it's sustainable and we drive that revenue. And there's a more definitive way that our specialists can bill for those services. When we think of the rural communities, I think we have to think of if these programs are increasing access to specialists, are there ancillary services that we can start to expand on, labs, imaging, et cetera, that we can distribute or we can perform here that might allow us to increase our revenue? Should we think of different payment models with managed care models in these communities now that we have some of these connection points or AI to help us manage the care for these patients and do some navigation support downstream that we can really take on risk? Is that something that we can explore with some of these payers? I think also I always like to look at the collaborative power. So a lot of these critical access hospitals, limited in a way in what they can do, but if they're a part of a rural collaborative, let's say, is there a way that you can have obviously your GPOs for group purchasing, but what other ways can we share services across communities? Can we centralize that so that maybe community A is a hub for a certain test, but community B has this other lab, and community C is the only one within these rurals that has L&D services, which is very true. I think in rural Nevada, I think only 3 of the critical access hospitals now are doing L&D services today. That number might be a little bit off, but it's not all of them. And I think that's something that people overlook when you think of, oh, well, there's a critical access hospital in this community. We can obviously deliver babies there. That's not always true. So just something as fundamental as delivering the baby, you think you can do that anywhere you go with the emergency room. That's not necessarily the case in the services that they provide there. So just thinking about that collaborative power across those rural communities, finding ways to collaborate, and then finding ways to hopefully use similar technologies so that as patients are flowing across those communities or broader, there are different ways that they can find value and streamline that. I think when I think of going back to your question earlier, sorry, of technologies that they're looking when I think of the collaborative power, I think of like a simple one is credentialing. A lot of these critical access hospitals want to get access to specialists. The big challenge from some of these groups that are delivering virtual specialties is your provider rotate across a large group that are licensed in that state. Well, now as a critical access hospital, if my outpatient department is hospital based, I still need you to be credentialed with my med staff and all the payers that we're going to bill for those services. That becomes a huge administrative burden where the idea of telemedicine connectivity is great. But if I can't support getting these providers credentialed, is that really driving value to my community? And so looking at things like that centralized credentialing hub through a collaborative, can we share some of those resources and the expertise? Are there AI tools that can streamline the process for credentialing with each of those facilities? That needs to be paired with the technology for telemedicine and the access to specialists to truly drive that value proposition. And so hopefully that's an example that hits on it. But I think that's where sometimes it's a lot deeper than just, oh, let's get the technology and we can have access to it. It's more of how do we create that sustainability? How do we drive value? And then to your point, how do we create revenue that can stay locally if we can keep these patients here what can we get from it? And from the hospital outpatient department, maybe there's a small reimbursement for the facility fee of that telemedicine consult, and maybe there's an additional lab or additional tests that they can do. And maybe if the patient has to go inpatient, they can keep them for a day or two, and see if they can stabilize them. And even if they do have to be transferred, can they be repatriated to our community because we have virtual nursing and we feel like we can keep that patient here? Because that's very impactful for a small rural hospital, critical access hospital. Every day in the patient bed is significant revenue for them. So hopefully I answer that question. I know I kind of went on a tangent though.
No, no, it's good stuff. I think the consortium and kind of or the collaborative model, however you want to label it, is a good one for leaders to consider because not everyone has the same needs and how, as a kind of an extended community, maybe you make all those pieces tie together, um, and really kind of creating those centers for specific needs. It's better than the alternative, right? Which is again, we take this for granted. I'm here in the Boston area. We have 3 children and all of them were born in the city. We say, when you talk to people in Boston, I'm sure it's like that for a lot of cities, right? We actually live in the suburbs, not in the city itself. But when it comes to labor and delivery, the example you gave earlier, you wouldn't want to have, this is, we're snobby, I guess, at this level we can be because we live near the city. So we can say we wouldn't want to have our kids anywhere but the city because God forbid something goes wrong. To be able to take from Brigham and Women's the Sky Bridge over to Boston Children's, right, and have that peace of mind and access to that kind of care. But again, many leaders who may be in big cities and maybe have lived in kind of these metro environments all their lives and worked in those environments, I think, I don't know if you ever encourage people to take a field trip, right? Like go out to the rural communities, see what those hospitals are like, see what some of these populations are like and kind of what they come in with. Like who comes into the hospital on a daily basis and for what kind of questions, issues, appointments, studies, those kind of things, and getting that perspective, real world reality of kind of what actual patients are dealing with. To me, that would be a valuable experience to kind of literally go out and see and speak with people.
I completely agree. I would say that one is that every critical access hospital is not the same. So they say once you see one, you've seen one, and it's very different for every different community. But to your point, that's a big part of whenever I had clinicians, medical directors, or leads of different teams join our telemedicine programs. A lot of times I would ask them, "Have you ever been to these communities? If not, let's go take a trip. Let's meet the administrators ourselves together. I'd love to show you around, and so you can better understand what the challenges are because." Sometimes things that we get very, I'll say, frustrated with, in an urban environment, those things are really tough to get. So, example is just a trained presenter for telemedicine, somebody that actually understands how to use some of the diagnostic equipment, stethoscopes, etc. Well, that's going to be tough to get in those rural communities without a formal training program for a telemedicine presenter because people that actually know how to use those clinical tools are likely doing clinical work in that community. And so you're going to be asking front office staff or back office staff to help your telemedicine presenters because you don't really have the budget or the resources to just bring on more people to do this. More you might be looking at volunteers, which again, what's the level of competency and the training to actually be able to support that telemedicine visit. And so I think it's very important that we think through it in the same way that you did. But we also have to think about how do we provide that level of support to make these types of programs work. And I think that goes back to the topic of change management. It's not just change for the provider delivering care, it's for everyone involved. It's for how do we present the patients, how do we use the equipment, how do we make sure we're successful with the right level of staff. And so for some places, that staff is not consistent day to day. And so, how do we make sure we have programs where we can train these people every day prior to whatever they need to deliver so they can support the patient care. And I'd really like to go back to change management, I think being a critical component of all of this, not just the culture of engaging in and adapting change and taking all the stakeholders' input up front and building the right workflows, but truly upon implementation, downstream support, continuing education with the technology, and continue evolution of the program. Because the technology changes so quickly, particularly today when this kind of AI boom, that a program that was built with a perfect workflow as efficient as it could be yesterday might be out of date tomorrow. And that's just the reality of how things evolve and how things change in healthcare and in technology. And so being able to have that culture of dynamic flexibility, always pushing to have the best program that's most efficient, most effective, but at the same time balancing that with what's the burden of the change management and the disruption in the workflow. We need to make sure there's a value add to it. Or maybe we need to take a pause and say, this is a great feature, but it might not be the right time to roll it out now. Let's bring it up in future conversations and think through when it might make sense. And that might be paired up with another update that comes with the technology downstream. So, kind of using that as an example that sometimes, even if it's the best feature that you want, it might not be the right time to implement it. And I think that's particularly true when working with rural communities.
Yeah, you've got to kind of be thoughtful and step yourself into it too, and think also about your population and what their needs are. What is the low hanging fruit that maybe you can go after and deliver some quick value and earn trust, right? That's always kind of in the background with all of this, earning trust with both the patients and their families as well as with the clinicians and the administrators of putting it all together. So as we wrap up here, if you're talking to a rural health leader now who's thinking about AI and the funding programs and transformation and all these kind of initiatives, what's the one piece of practical advice that you'd give them or ideas of where to start?
Yeah, I think the first practical advice I'd give is look at the challenges that you currently have that you're actively trying to solve. And let's look through and work through what the challenges are. Be very honest with yourself. And sometimes AI or technology isn't necessarily the answer. Sometimes it's a workflow issue. So I think start there, understanding what your key drivers are for change. Look at your workflow and then determine where does technology fit and can we find the right technology for us that's going to fit this gap. And I'll say the right technology for you is not always the technology that you read about that's been used by the most companies across the country, but sometimes it's the one that just has the right tools for you at the right price point. Sometimes we don't always need that Cadillac suite, if you will, of services, and sometimes you need just the vehicle that's going to help you get to the next place. But obviously, as I say that, I also say build with the long-term vision in mind. Don't build something just to solve the gap today, but think about what that gap will look like in 5 years, in 10 years, and build something that you think, even if it's not the solution then, will be the foundation for what will be required to drive that gap or to close that gap downstream. And then the last thing I'll say is I challenge you to be creative and think through this 50 billion in 5 years is something that is likely a once in a lifetime opportunity. And so be a dreamer. Think through what it would be like to have all this technology within your organization and what that vision would look like so you can kind of imagine what that future is. And obviously, as you build that out, do it in a piecemeal fashion. So you bite off what you can chew in year one to year two to year three. Have a great strategy and growth plan, focus on that change management, but also don't ever lose sight of the value drivers for why you're doing what you're doing. I think sometimes with technology, shiny objects, we can kind of get lost in the hype. And the most important thing is that we ground ourselves in the value that we want to provide for our community. And so as we're looking at technology, it's a great time, but we also need to know that it's going to have the right outcome, the right delivery, that we have the right people and processes in place. And I think technology is the last component. Partake with how many vendors are out there today. You can find somebody that will likely do what you need, or somebody will build it for you. But it's really about getting the stakeholders engaged, finding the right gaps that are going to drive value, and quantifying what that value is and defining that future so that as you're having conversations with your team, your staff, you can really articulate what that future is and that technology isn't here to replace them. It's here to actually elevate them and the level of care we can bring to this community. And I think that in itself will be probably one of the largest challenge for rural healthcare administrators when looking at applying for these funds and using new technology is a stigma that they're trying to replace jobs in their community, and having to get upstream of that first and foremost, as well as the change management with the culture, I think are things that are vital to having a successful program, but also having people be excited about using the technology once you have it implemented.
Yeah. Very well said, very practical and well-grounded advice. A lot of thought can go into this and kind of the planning and obviously partnering with experts in the field who have done this kind of work before for advice and recommendations is always something to consider. So Mitchell, if people want to reach out and connect with you, where should they go?
Yeah, please. My email would be great, or else innovizeconsulting.com. My website is a great place to learn about our services and connect with us. Would love to work with anyone out there. I think A big focus for us is that equitable access to quality care and focusing on where technology can close those gaps in a sustainable way. Rural communities are a big focus for us. So please reach out. Would love to hear about what you're doing, even if it doesn't lead to an opportunity. I'm just a big fan of connecting with people and learning what's out there and what you guys are all doing. So please connect with me. Tell me what I missed. Tell me what was good and tell me how I can get better.
That's great. Well, thank you for that generous offer. So, with that, we'll say thank you, Mitchell, for being with us today. Great time and a lot of insightful comments here.
Thank you, Mike. Appreciate the time.
All right. Well, thanks for listening to the Health Tech Edge. If you found this useful, share it with someone in your network who's working on healthcare operations or trying to figure out how to apply AI in a practical way. And if you want more conversations like this, make sure you're subscribed so you don't miss the next episode. We will see you next time on the Health Tech Edge.